understanding of Strabismus, not advanced understanding of Strabismus. So, at one level, and try to come down at one level, so that you understand the basic principles in the nature. You understand? So, I have given you a classification or a different branch of knowledge. One more branch is group. What is group? People do not know group. So, these are sub-branches like coordinate attack one, glaucoma, then the chirurgy, then the vitreoretinal, then the Strabismus, the oxygen, then the vitreoretinal, then cognitive. That's one. There's one more branch that's called neuro. That's called neuro. That's one more subject. So we go back to the treatment modalities of this Strabismus. Okay. So there is three, as you know, there are two types of management. One non-surgical, other is the surgical. So we will discuss first non-surgical, then we will discuss surgical. So non-surgical and surgical. So what we do? So what are the principles as related to the aims of treatment of Strabismus is restore good visual acuity, achieve satisfactory cosmetic appearance, and restore the posture to normal vision. So by Squint, you have problem with the vision. If you can restore vision, that's this. Other than cosmetic, you can see that there is Squint. Okay? So this is a problem with most of the people, especially young generation, who depend on marrying of this, become the cosmetic, unacceptable. Then third is the restoring vision, good vision, or restoring normal vision. Maybe normal vision 66 may not be possible. There may be a compromise like 612, 618. So that is the new experience of this treatment. So, in non-surgical treatment modalities, we have non-surgical treatment modalities. We have first of kind of treatment, that is the glasses. That is the glasses. So, because if you have already read about the convergent surgery, you understand? There is an element of hypermetropia. There is an element of hypermetropia. And in iso means inward deviation. So in that there is hypermetropia. If you have outward deviation, that is called exotropia. That is called exotropia. In that there is an element of myopia. You understand? So high hypermetropia causes esotropia, and high myopia can cause exotropia. So first of all, we have to give glasses first. We have to give glasses. Why? Because what causes high hypermetropia? Because convergence. Because there is no accommodation. There is no accommodation. What is the difference between accommodation and convergence? One by one. Anybody will get that? You get? Not really. That's fine. But how do you diopters there is a change. And convergence is a function of medial lines. The convergence of the two. For medial lines will pull the eyeball inwards. So one is this most of the patient has high hypermetropia, plus 4, plus 5, plus 10, and he is not able to see clearly. Okay? Eye goes to a hyper accommodated state. There is in children, there is a large accommodation reserve. So once they observe more to see the real objects, there is more accommodation. And once there is more accommodation, the convergence of eye increases, eye growth increases too. This is called accommodation convergence by accommodation. Convergence by accommodation has to be determined. How much convergence occurs by changing accommodation? So there is a problem in high hypermetropia. The convergence occurs more due to high accommodation, and the eye turns inwards. Inwards, what we call growth. So in them, if you do simply, suppose there is a Squint or 15 degrees, 30 degrees or 45 degrees, whatever, if we give glasses, suppose we give plus 4 or plus 5 to them, it will be correct. You understand? That's what's needed. It doesn't mean anything more. So this is one of the non-surgical means of Squint correction. So in them, there is one called bifocal glass. That's called bifocal. They give for distance as well as for near the eye. Okay. Then in some cases of suppose you can give prisms which increase the focus of the eye. But they are less used. Prisms are not generally used. Then we use high convex glasses. High convex glass like plus 5, plus 10, plus 15 like that. Then if the patient has myopia and acute, okay, so you can give in them what? Myopic glass. You can give myopia, but you can under-correct. Or you can give a minus near vision, minus for the near vision, so that the convergence is skewed. Convergence is because eye is not out. So you want the eye to go in now. So you will decrease the near vision by a minus. Then we have the pharmacological field. Then we have the pharmacological field. What pharmacological field? Pharmacological field means if we increase the accommodation by some drug, it can increase the resolution. Which drug can increase the accommodation? Parasympathomimic. Okay, parasympathomimic drugs. And what is the philosophical drug which is used in the eye of parasympathomimic drug? Spinal cord. That spinal cord we can use to increase the accommodation. To increase the accommodation. That is non-surgical way of correcting the result. That is one of the class of drugs. They are called midratics. They are called midratics. In which they can be used. They can be used to absorb protein. The eye damages outwards. So midratics can be used in exotropia. And biotics can be used in esotropia, in the way. That's the way I have told you in eye hypermetropia. So these are the two classes of drugs which are used. Then any other drug? Botulinum toxin. Botulinum toxin. Because why? Because that is a sort of a chemodegeneration of the muscle. That's a chemodegeneration of the muscle. Suppose somebody has lateral plexus palsy. Somebody has lateral plexus palsy like the fourth palsy. And what will happen? We will not be able to see lateral. I will not move lateral. Understand? Oh, yeah. Come forward. This way. Come forward. Find back to position here. Oh, yeah. Come here. Then you move here. Sit here only. Sit here on that way. On this end. Yes. So we have now a hemodynamic. So once there is lateral access, now you will give a toxin, botulinum toxin to the bigger legs. You will give a botulinum toxin in the middle legs. So the middle legs will get paralyzed. Okay. Once it will get paralyzed, I will move. You understand? I will move. Suppose there is a middle legs paralysis. I have turned out. I have turned out. So you will get, you will be botulinum toxin. It will straighten. That is the concept. So botulinum A toxin is used for treating strabismus. Because of the neurological, okay, they are neurological, like third or fourth or sixth paralysis. They take some time, like 3 months, 4 months, 5 months, 6 months to recover. So during that time, you can use botulinum toxin, okay, to make the cosmetically better. Then we have one more problem, and this is that if there is paralysis, lateral rectus paralysis, there is a lateral rectus paralysis. If it is not recovered over a period, like 2 months, 3 months, 5 months, 6 months, what will happen? It will go into fibrosis. Okay, then it will, even if neurologically muscle is active, it will not. So in that, botulinum toxin helps in recovering of the function. Once you suppose there is a medial rectus paralysis and you give botulinum toxin to the lateral rectus, the fibrosis will not occur. You understand? That's how the botulinum toxin happens. Any other? Then we have amblyopia. Then we have amblyopia. Amblyopia is what? There is a decrease in the visual acuity or whatever. Because the eye is deprivated of students. Eye has gone in or out. You understand? This is called strabismic amblyopia. This is called strabismic amblyopia. What's the treatment for that? Patching of normal. Very good. Patching of the normal. One method. How many years will you do that? Remember, 2 years old for 2 days, 3 years old, 3 days, 4 years old, 4 days, 5 years old, 5 days, 6 years old, 6 days. You understand? But suppose child is 6 years old and he has light skin, is over active. Now you will occlude the normal. You will occlude the normal. This eye will take fixation. This eye takes fixation. Once this will take fixation, 6 days, after 6 days we have to occlude the normal. This is what I want to talk about. Why? Otherwise should not go into amblyopia. Otherwise should not go into amblyopia. This is a precaution. Is it? Precaution. So this is once the vision comes, suppose there is a vision of 612, 624. So you will increase the range. If the 624, you will be back to the 612 because that's a better. You will be back in the better. So 624, you will be less better, like 3:1. 3 days for the 612 and 1 day for the 624. Once the vision becomes equal in both, like 612, 612, 69, 69, 618, 618, then you will go for alternate. You will go for alternate. One day in the right eye, 1 day in the left. This is the principle. And patching are 2 types. One is part-time patching, other is full-time patching. Full-time means morning 9 up to evening 6. Morning 9 at evening 6. That's full-time. there's a bad, so in them the part that most of the authorities recommend full-time back. Okay. Then we have one more problem with the banking. You should understand that. You cannot give banking like this. You have to give first glasses, then bag. First glasses, then bag. Suppose somebody has hypertension. First 5 plus 10. If you not bag, if you not use glasses, batching will not happen. First you have to give glasses, then you have to use batch. In the other method, we can use mid-rags. We can use mid-rags. How to mid-rags is the way packing happens. Packing, that means what? That means the abnormal eye to function. Suppose we dilate the normal, we dilate the normal, we didn't become blur on that. So patient will use in the abnormal. That's how it's called penalization. It's called penalization. Penalization. And which drugs are used? Cyclopentolate 2% or atropine 9 drops or atropine 5 drops. Because the drops are problem for the children, like 2 years, 3 years, or the kid persistent toxicity. So in those cases we will point to. So this was something about the growth limits. So and one more is the orthotic limit. What's orthotic limit? Clearly with the right eye. Left eye is vision is clear. So what will brain do? It will suppress the image of the eye. This is called suppression. This is called suppression. Another point, another is called abnormal retinal correspondence. Abnormal retinal correspondence. What does it mean? Basically, every point in the right eye corresponds to every point in the left eye. If there is disparity between the two, that's called abnormal retinal correspondence. I'll explain you. Suppose this is the right eyeball and this is the left eyeball. Right forehead is matched to left forehead. Okay? Any point on the nasal side, any point on the nasal side of the retina, right eye, is corresponding to the any point in the temporal part of the left eye. So nasal of this, temporal of this. Nasal of this, temporal of this. Okay? So these are corresponding points. So we look here. We look here. So nasal point of this side and temporal point of this. So I am looking at that. So nasal point of this, temporal point of that. So if I look at it like this, so it is the nasal point of this and the temporal point of that. Okay? So that is called retinal correspondence. It's called retinal correspondence. If there is a brain, there are not corresponding points for I is not in or out, whatever. So there is abnormal retinal correspondence. Phobia of right eye, non-phobia of left eye. This is called abnormal retinal correspondence. And this one more, what is called stereops. That's called stereops. What is stereops? The depth perception. Suppose that window is here. How much is this wooden frame inside or outside the glass window? That depth comes with both kinds of frame. So this is a problem with stereops. That can happen when there is speed and there is advanced critical is not functioning properly. So that can happen. So in all these cases, like stereops, like abnormal retinal correspondence or suppression, we use orthotic exercises. We use orthotic exercises which are done on a machine called a silent foot. And this is called orthotic treatment. It's called orthotic treatment. And this one called fusion. That's called fusion. That's called fusion. What's fusion? Because one image is one object. There is one object which follows the formula of right and formula of left. So it interprets the coordinate amount. This is called fusion. This is called fusion. So all the cases of abnormal correspondence, suppression, stereopsis, fusion, the orthotic represents of view on the side of the phone or sometimes otherwise. Suppose somebody has convergence deficiency. Convergence deficiency. So in that we can do some exercise like this. Take off the pen, bring it to the close eye, bring it so that the needle has a student. Okay? So increase the versions form of eye. So this was the complete. Now we will come to the surgery. We come to the surgery. As I told you, the refractive correction. That you read how this is connected. Glass diagram. Glass diagram. This one that will not be minus. One of all the equations. These are all those parasitic mimetic drugs, hydrochloroquine or superchemistry or other things. You could use them all. What's what we do in that room? What are the aims of surgical treatment? Is to correct skin cosmetically as a function. But to correct skin only cosmetically. If someone is a long-term amblyopia, even if we correct the eye, the straight vision, the vision will not be restored. Then the astronomic symptom. Astronomic symptom means what? But if the eye had aims like that, so, what is one problem? Sitting is somewhat abnormal like that. But in up, it is not sitting in up or in down or like this. So, that means sitting time. lateral axis is 7.5 and superior axis is 7.9. All other muscles, 6 is called what spiral of locks. Okay? Again remember 5.5, 6.5, 6.9, 7.7. 5.5 most anterior. 6.5 behind that. 6.9 behind that. And 7.7 behind that. So this is called spiral of inox. So the medial pelvis is the only muscle. That is the only muscle which does not have facial connection. It does not have facial connection with what? With other muscles. Okay? We have inferior retractors of the limb. If this problem inferior retractors of the limb, what can happen? It is called acropion or acropion. Okay? So it does not have facial connection with anything. And one more difference is because medial pelvis is more anterior. It is more anterior. Once it is more anterior, what will happen? Its arc of contact with the globe is less. Its arc of contact is less. Other muscles have more arc of contact with the globe. So, if we know some muscle is long, not long, it's normal, then if we cut it, what we do? Insertion regard. Then suppose we remove 2 mm, 3 mm or 5 mm muscle, then we reinsert it at the insertion site. This is called resection. This is called resection. We have resected part of the muscle. We have resected part of the muscle. This is called resection. Then, how much resection do we do? Medial legs we can do a 6 mm resection maximum. How much? 6 mm. And lateral leg is 8 mm. Lateral leg is 8 mm, not beyond. Okay. So, resection is a less powerful than recession. Then recession, resection it corrects almost 1 mm, corrects around 1 degree of skin. Okay. So this was about something about the resection. Other is what? Other strengthening procedure is called advancement. When is advancement? We have done research. We have done medial research. Why do we want to do medial research? Because I have done now. So we want to strengthen the medial research. We have done. There is still some dimension. There is still some outward dimension. So what we'll do? We'll bring this muscle more and more. Suppose there is 5.5 mm. We'll put it at 4 mm. This is called advancement. Advancement. So there are 2 things. One is section and other is advancement. Is there any other more to this? Okay, we'll come to this anatomy. Then we'll come to the muscle weakening procedure. Muscle weakening procedure. What are the muscle weakening procedures? Recession. What do we mean by recession? We cut the muscle. We cut the muscle. We don't cut the knee. We cut the insertion, not the muscle. Once we cut the insertion, we place it behind. We place it behind. Okay, suppose medial legs, suppose at 5.5 mm from the leg is inserted now. Suppose now instead of 5.5, we will put it at 8.5. So we have resisted at by 3 mm. By 3 mm. So 3 mm recession Suppose how we are using the session. How we do it? How we are using this session? Suppose I is deviated out. What you need to do? You will come to the lateral lines. So we will do the resection of right lateral lines. Okay? Am I right or wrong? No, I'm wrong. So this I is deviated out. Okay. So you will do the resection of the medial lines. You will do the resection of the medial lines. So you will do the resection of the medial lines. And lateral lines, what you will do? You will do is recession. Suppose we do this 15 degrees or 20 degrees, okay, on the right side. I will give it out. What you will do? You will do a 3 mm or 4 mm resection of the medial lines and 3 mm or 4 mm recession of the lines. That's how it's come out. Resection with recession. Then one more, you can do one more thing. Suppose patient has outward deviation to the right side, 15 degrees or 20 degrees. You can do a bilateral resection in both. You will recess. You will do a resection. You will do a resection of both medial black threads of 2 hours. So you can operate in both eyes or you can operate in one eye. I need to say that. So resection, strengthening is a strengthening procedure and recession is a weakening procedure of a particular style. And recession is more powerful than resection. So more than this we have the other procedures what's called myotomy. What's called myotomy. Or this called myectomy or free venotomy or post-fixation surgery and recession of conjunctival and dense tissue or muscle lengthening by bands of this. So you can understand these procedures how they are done. I just have concept of these or no? I want silence, no side talk. I'll explain you a bit of different procedures. Is there any? What we have done, we have inserted here. Okay? So we have resisted at 8.5. This is called recession. So this is called recession. This will be called recession step. Then we have second situation. Again, the eye is here. Eye is here. You have a muscle. Like this. What you have done here? So this is a muscle belly. You have to mix. You understand? You have are given next on two sides. One knee on this side, one knee on this side. One knee on this side, it has become what? That's called the treatment. This is called what? This is called myectomy, not myectomy. एक करो myotomy. This is called myotomy. There is one more. Suppose eyes are normal in function. You are seeing straight, there is no straight. What do you do? Once you close the left eye, the right eye goes up. What is that? No, that's not called left. Hypertrophy is the primary illness. That's called PPP. Systematic vertical deviation. That's called systematic vertical deviation. In that, one procedure is done. Superior left muscle, we put a suture. We put a suture behind the equator. That weakens it. That weakens it. Like this. So this is the muscle. This is down to the insertion side. And the insertion side, you know, is around 7.9. What I told you. 5.5, 6.5, 6.9, 7.7. Okay, not 9, 7.7. 7.7. Okay? 7%. What we do, we will put a suture here. And we will put a suture behind the equator. What is the equator of the group? 8 mm behind the lens. How much? 8 mm. Though in Squint varies from meter like this, like this. Minimum behind the lens is okay. It can be 10, it can be 12, it can be 14. So you put a suture and through the tendon you will make several pass and you will make the separating procedure. And this procedure is called padding. What's called? Padding. It's called padding. One more procedure is that is called what? What is it? Hanky back. What's called? Hanky back. What is doing that? So this is the muscle and this is the insertion. This is the insertion. They will make this movement like that. They will not insert the muscle, they will make a long suture loose, which is loose. So that is a weakening kind of procedure. That's a weakening kind, recession kind. So suppose you want to make recession more powerful, then this is called anti-back. Okay? So in anti-back we put a loose suture and which is attached to this. In Strabismus we put a suture to the sclera behind the equator, and in myotomy we put cuts on the muscle belly on two sides. Okay, that is what? A lengthening of the muscle, and that was the weakening of this. Then we have this recession, which I have made to understand how the recession was weakening. Any other procedure we are doing? Yes. We are doing one more that's called, suppose it's the globe, and the superior legs will come like this, and the inferior oblique will come like this, below it. Okay? Because superior oblique, not superior legs and superior oblique. Superior legs will come like this, the superior oblique that will go to the middle part of the orbit, then back that go like this, below this muscle. And once this muscle is stored, suppose if you go and you just you either do one thing, you cut this There is one more procedure. You can do its anterior fibers only. Keep the posterior fibers here. That's called partial tendency. That's called partial tendency. You can do one more thing. You can completely cut it here. You can completely cut here. Bring it here. Put it nasally on this side. That's called nasalization of what? Okay, that's called nasal transposition. That's called nasal transposition of what? Superior oblique. So these are the procedures done on the superior oblique. The inferior oblique muscle. Again, we do the same things. Why is the umbilical cavity? Why is the inferior oblique inserted? Inferior oblique, not inferior rectus. Corresponding to the macula, so much behind it. What is the difference between rectal and oblique? Rectal are inserted in front of this, and obliques are placed behind it. That's the big difference. And that's why there is a opposite. Suppose superior rectus will lift the arm, inferior rectus will depress the arm, superior oblique will depress the arm. Because it is inserted what? Behind the atrium. And inferior oblique is inserted behind the atrium. So it will lift the arm. So their action is antagonistic to the rectum. So you should be very clear. Inferior oblique goes from the floor of the orbit, from the medial side, it will insert at the signature near the macula. So if we do a recession, if we just cut the tendon here, so it comes like this, goes behind, and it goes behind the near the corner behind the equator. So if we just insert, okay, and we recess it, we put it down. This is called recession of the front of 4 mm or 5 mm front. That's called anterior transposition of what? Anterior transposition of inferior. So these are the different procedures which are done to address the weakening part of it. Okay. So behind the growth, we just give an idea. What are the complications of this? First, number one, people operate on the wrong way. Okay? So once you have to right, the operate eye is wrong. Say that there is a child, you turn over the time of the student, he has put in the general anesthesia, now everybody forgets which eye has it. Okay? This is called one. You write these things. One is the wrong one. One is this wrong. Number second, important is that you have done the procedure to the wrong person. You have to do rectus recession, you have done medial rectus recession. You understand? You have to do a medial rectus resection, you have done lateral rectus resection. So wrong person. So we are hooking the muscle. We are hooking the muscle. You have to advance the movement. So you can damage the muscle belly or muscle sheath, or there can be hemorrhage because of that. Hemorrhage. So these are the problems with these procedures. Any other? There is one more because the insertion of the muscle or the sclera. The sclera is thinnest of that. At that point or behind that. That's 0.3 mm. How much? So while passing through here, you have to be careful. You can cause proliferation. You can cause. So while you are passing the needle from the sclera, you should visibly see parts of it. And there are some high myopes which have very thin sclera, and in them the perforation of the sclera is in higher chance. Normally, what is the sclera thickness? It's around 0.5 mm. How much? 0.5 mm. And from anterior to posterior it increases. Okay, but at the insertion of the muscles, it is only 0.3. It's 0.3. So at that side, if you bring this window, it can cause scleral perforation. So we have to be very careful. Then you can have, because you have to subject the child to general anesthesia. You can have general anesthesia complication. Okay, you can have general anesthesia complications. These were the immediate intro. They were the immediate intro. There is no more problem. Normally they say we should operate on 2 rectangles. We should operate on 2 rectangles, not 3. Why? Because the vessels which innervate the rectal muscle, they supply to the anterior segment. This is they supply the anterior segment of the eye. And if you operate on 3 muscles, it becomes ischemic, and that's called anterior ischemic syndrome. That's called anterior ischemic syndrome. And that anterior ischemic syndrome is characterized by cold breathing and signs of UIs and eyes and drop. What are signs of UIs? They can have cavities. Hypopia is very advanced. Initial is cavities. Okay? Then we have the explain. Then we can have eyes atrophy. Then in the long term we can have cataract. So these are the problems of generally the recommendation is not to operate on more than 2 rectal muscles. You know how many shots in the artery branch are there in the 4 rectal? There are 7. There are 7. 2 to each and 1 to non-rectal muscle. I think that's lateral practice.
Yes.
To lateral rectal muscle, there is only 1. So superior, medial, and inferior, there are 2 branches. There are 2 branches. Once you are operating on 3 muscles, it will cause anterior ischemic syndrome. What else can cause the long? There can be under-correction or there can be over-correction. Suppose second is 40 degrees. You have corrected only 40 degrees. So this is under-correction. Second is 40. It was converted second. Now it has gone divergent. This is over-correction. This is over-correction. Suppose you have not sutured the canal capsule or conjunctiva properly, it can cause granuloma. It can cause granuloma. You understand? Or there can be sutured granuloma. There can be sutured granuloma. Or there can be a fat prolapse. There can be, once we are cutting the tendons, so the periorbital fat can protrude out. That's called periorbital fat protrusion. You understand? That's called periorbital fat protrusion.